This meeting is being recorded.
Good evening. Welcome, everybody. My name is Deborah Duran. I'm Chief Nursing Officer for DHS, Department of Health Services in Los Angeles County. And my role here today is that I serve as a member of the DEN. We're super excited to have you feel welcome. Happy Ambulatory Care Nurses Week to everybody. If you're a member, you got your little magnet in the mail. So happy Ambulatory Care Nurses Week. Before we get started, I wanted to take a moment to go over a few things that you'll need to know. The participants in today's webinar will need to complete the Nursing Continuing Professional Development Process, also known as CNE, by evaluating the webinar at the end of the session and retrieving your certificate of attendance. This process is completed online, and the AAACN National Office will send out information about how you can complete your evaluation. We also would like today's webinar to be interactive, and we encourage you to submit questions to our presenter using the questions area, which you should see at the bottom of your Zoom window. Please feel free to submit your questions at any time, and our speaker will do her best to address your questions verbally prior to the end of the program. We have a few polling questions that we'd like you to participate in during the webinar, and you should see those. They should pop up on your screen for you to respond to. So with that, I'd like to introduce our lovely speaker. We're really excited to have Dr. Ackerman-Barger here joining us today. She is Associate Dean for Health Equity, Diversity, and Inclusion, Clinical Professor and Director of Faculty Development for Education and Teaching. She is Associate Dean and a Clinical Professor at the Betty Irene Moore School of Nursing at UC Davis. She is also the Director of Faculty Development for Education and Teaching and co-director for the Interprofessional Teaching Scholars Program. As Associate Dean for Health Equity, Diversity, and Inclusion, Dr. Ackerman-Barger leads the school's efforts to create a diverse and welcome setting in which to learn, work, and collaborate. She also designs initiatives so the school's learning environments, workforce programs, services, and partnerships are more diverse and inclusive. So important. Ackerman-Barger's academic interests relate to health equity and social justice. Over her career, she has combined her expertise in nursing and education to advance inclusive learning environments, education equity, and workforce diversity. She is a national consultant and speaker on strategies to help underserved and underrepresented groups in health professions thrive academically. Dr. Ackerman-Barger earned her Bachelor of Science in Nursing from Humboldt State University. She earned a Master of Science in Nursing Education from Cal State University, Sacramento, and a Doctor of Philosophy in Nursing Education from University of Northern Colorado. Her ongoing interdisciplinary work has been recognized through fellowship in the American Academy of Nurses, the 2019 UC Davis Charles P. Nash Award, the 2016 UC Davis Chancellor's Achievement Award for Diversity and Community, the 2019 Dean's Award for Excellence in Equity, Diversity, and Inclusion, 4 Dean's Team Awards for Inclusion Excellence, the 2017 Dean's Award for Excellence in Mentoring and Early to Mid-Career Level, the 2020 Dignity Health Dean's Leadership Award for Excellence in Diversity and Inclusion, and an award for Teaching Excellence. She has disseminated her scholarships in publications, including Journal of Nursing Education, Nursing Education Perspectives, Journal of Best Practices in Health Professions, Diversity, Academic Medicine, and Journal of the National Black Nurses Association. Very, very accomplished woman. Thank you for joining us. And with that, I will hand it over to you, Dr. Ackerman-Barger.
Wonderful. Thank you so much for that introduction. And thank you so much for inviting me. I really appreciate that. Let me get my slides up and ready for y'all. Always has like a little moment delay. Deborah, can you see my slides? Can you just give me a thumbs up?
Yes. Yeah.
All right, lovely. Okay, well, let us talk about cultural humility as a framework for promoting health equity. So just to start us off, I would like to share with you a little quote from the Future of Nursing Report 2020-2030. This is on page 3 and 4. They say a nation cannot fully thrive until everyone, no matter who they are, where they live, or how much money they make, can live the healthiest possible life. And helping people live their healthiest life is and always has been the essential role of nurses. Nurses then have a critical role to play in achieving the goal of health equity. And one of the reasons that I like to share this quote is that as I've had conversations with nurses and healthcare providers, really, and we talk about things like social determinants of health, health disparities, health equity, they say, you know, these problems are interesting, but what do they have to do with me? And so my goal with a lot of these educational opportunities is to really help people see that you're needed as an individual, as a care provider, and then as a member of your health profession. And that's really the framework that we're going to work on today. So I want to go over just some of the terminology. And what I've noticed is in some of the discourse around equity and equality, it seems like sometimes people are making it so that these two terms are in competition. And really, I want to outline that these terms are not in competition with each other. They actually complement each other, but they mean different things. So equality is a word and a concept that has been near and dear to those of us in the United States. It's part of our Bill of Rights. And it really has to do with human rights and the idea of valuing individuals and communities. Now, here's the thing is that when we start out in life, we don't have the same access to resources, opportunities, services. Maybe it's based on where we lived. Maybe it is based on socioeconomic status, race, ethnicity, all of these different things. It can be people that live with diverse abilities, right? And so the idea is that everyone should have a fair and just access to the services, opportunities, and resources within a society, yet we need to cater that to the needs of individuals and communities. So it doesn't really make sense to have everybody have the exact same thing. It should be based on need rather than the same. And I'm going to go into what I mean by that a little bit more. I am guessing probably a lot of you have seen this image before. And basically what this image is trying to outline is that that when we treat people the same, sometimes it's not a great thing. And so in the top visual, everyone has access to transportation in the form of a bicycle. And that bicycle is exactly the same for everyone. And so the woman riding the bicycle, she's happy, it works perfect. But for the kid and for the guy that's really tall, that bike's not working out really well. And for the person that's in a wheelchair, the bike is essentially useless. And so in an equity model, yes, everyone would have access to transportation, but that transportation would be according to need. And so in the bottom picture, you see that there's a smaller bike for the child, a taller bike for the man, and then there's a modified bicycle for the person with diverse ability. So in terms of patients, like if you were to see a patient, say, maybe in the ambulatory care setting, and they came in with a laceration, we would probably give them maybe stitches or a Band-Aid. But in an equality model, if somebody came in with a broken leg, well, we don't want to treat people differently, so they also get stitches and a Band-Aid. And if somebody comes in with a broken heart, guess what? Stitches and a Band-Aid. But in an equity model, if somebody came in with a lac, they'd get what they needed, stitches and a Band-Aid. Broken leg cast and broken heart, they would get a hug, right? And so that's the idea, that we're going to meet our patients where they are. And for people that teach, you know, we shouldn't be treating our students the same either. We should treat them fairly. We should treat them justly, but every student learns differently. And so we need to meet them where they are with their needs. So when I've had students say, you're treating me differently than other students, and I'm like, yes, of course I am. You're welcome for that. I'm treating you as the individual with your own experiences and your own specific needs. So, excuse me, let's go over a couple of definitions. Here's a definition of health equity from Dr. Kamara Jones. She says that health equity is the assurance of the conditions for optimal health for all people. Achieving health equity requires valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need. Health disparities will be eliminated when health equity is achieved. In just a moment to talk about health disparities. Health disparities are a measurement, they're a metric, and something that we use to see are certain groups experiencing more poor health outcomes than other groups of people. And so the notion is that we really shouldn't see variation across gender, single moms, race, ethnicity, socioeconomic status, geographic location. So looking at health disparities is some of the most robust information that we have in health professions, but just looking at it and gathering that data doesn't do anything. The idea is that we need to be doing something about it so that those numbers are actually changing. From a journal article from Joya Creer-Perry and her colleagues, she's actually talking about maternal health, but one of the things that they talk about in their article is how important it is to look at the root causes of health inequity. So they say, by defining the root causes of health inequities, we can move the focus of intervention away from individual blame and misguided theories of the biological basis of race and ethnicity. And so, one of the things that we do sometimes in healthcare is that we blame groups for the circumstances they find themselves in, or we say because of their race and ethnicity, there's nothing that we can do about it. And both of those things can be difficult. One, I want to point out that there is really no genetic difference between people based on the color of their skin. That is an absolute misnomer. We do know that there are differences based on ancestry, but some of those differences can be, seen across race, ethnicity, or within those groups. And if you think about like the way that we lump groups of people together, if you're going to talk about Black people, there's an entire continent with many, many countries and tons of biodiversity. And so what are you talking about when you talk about white people, Black people? When you talk about white people, same thing. White people come from all over the globe. How are you going to make a generalization? Asian people, right? Those categories are so broad that you just completely miss any ability to make predictions based on somebody's race and ethnicity. The other thing that we do then is we will blame individuals for their circumstances. So people that come into the clinic with obesity, diabetes, heart disease, a lot of times we say, well, you need to diet and exercise. And, in addition to being completely unhelpful, right? Like a first grader could give you that. I don't need to go to a clinic for that. And of course, it's not that easy to make those modifications, particularly if there are other things that are happening. It's hard to exercise when you live in an area where it's actually dangerous to go outside, or where there's smog or traffic or violence or those sorts of things. Sometimes it's not that easy to eat healthfully if you don't have the means to do that, right? And we know that people of color have a higher risk for things like obesity, diabetes, and cardiovascular disease, but it's not based on race and ethnicity. It is based on the social and political determinants of health. It's not a genetic predisposition. It is socially and politically determined. So this article reminds us that we need to really be going upstream to understand the health outcomes that we're seeing within our clinics. So let's look at the notion of health equity as a wicked problem. And what I mean by wicked problem is that there are so many things that make up the components of health inequities, health disparities. We always want, like, what's the singular solution? How are we going to fix this? But this problem is complicated, and there are many factors that are involved. There are many different opinions about how to reach equity. And so sometimes it feels like it's unsolvable. But I do believe that if we are committed, if we are patient, if we continue to do the work, we will make progress. I know that I won't see the thing called health equity in my lifetime, but it doesn't mean that I'm not going to set the stage for future generations to get there. So in understanding the wicked nature of the problems that we see, I have created this visual. We hear on the news and in conversations this term called systemic racism. I'd like to say systemic racism and systemic inequities, because it's not just race that we see inequities, it's, you know, across the board. And to understand the systemic nature of it, we need to understand that systemic includes structural, institutional, and individual racism or inequities. So let's get into structural. Structural refers to things like laws, policies, practices. It can even be the physical structures. If you're somebody that has a diverse ability, you know that a lot of our buildings are built in a way that instantly makes it more difficult for you to sometimes access healthcare or education or the legal system, or just to get back and forth on the sidewalk. Institutional racism. This is looking at the practices of institutions and organizations. A lot of times organizations will say, this is our policy and our practice. And it's not like it's governed by a law. It's that the institution or the organization has decided to do that. And oftentimes we can undecide to do that as well. For example, during the pandemic, we saw a lot of things change that personally I thought could have changed a long time ago. As a consumer of healthcare, you know, years ago, I'm like, why do I need to come into the clinic for this? We could just have a conversation about it over the phone, or we can use technology like Skype and Zoom, you know, leaving the HIPAA side apart. But we have the know-how and the technology to do this, but institutions just didn't really feel like changing it. And when it came down to it, lo and behold, we're able to do like this telemedicine thing and make it a little more accessible, right? So those are institutional decisions. There's no law preventing it. It's just, that's not how we did it. And nobody really particularly wanted to change it. And then when we talk about individual racism or individual inequities, we're talking about human interactions. It's like the way that we treat each other. So I am going to share a quote with you from Nicole Hannah-Jones. This is from an interview that she did with the American Academy of Medical Colleges. So this is the quote. Nicole Hannah-Jones said, "When we talk about systemic inequality, it kind of alleviates us from acting," she said. "We can kind of throw our hands up and say, well, it's too big. It was created a long time ago. There's nothing I can do personally," but that's not true. It was created intentionally, which means it can be intentionally undone. The question is, are we willing to put the same amount of effort into undoing inequality as we did into creating it, right? So I said before that we're talking about a wicked problem. And so there's just not going to be a singular solution. There are multiple things that we need to look at the individual, institutional, and structural level. But what I do want to offer is a framework that can help us navigate how to get to the solutions, the problem solving, the innovation that can ultimately mean health equity. And so we're going to talk a little bit about the concept of cultural humility. We first saw the term cultural humility in the literature in an article written by Drs. Melanie Turbalon and Jean-Marie Garcia in 1998. This is the title of the article. It's still a very salient article. If you haven't had a chance to read it, I recommend that you access this article. And I'm going to go a little bit through, I'm going to introduce you to both of them, like sort of introduce you, and to some of the main tenets of cultural humility. They right now are working on a book that should be out. We're hoping that it'll be out this year. And I have the great joy of getting to co-author a nursing companion book to that with Dr. Jan Marie Garcia. And so I get to talk with them and work on some of the concepts around cultural humility. So it's my honor to get to share some of that with you. So this is Dr. Melanie Turvalon. She's a physician. She has a master's in public health, and she's a pediatrician. And then this is Dr. Jan Marie Garcia. She is also trained as a physician. She has a master's in public health and was trained as a pediatrician. She is a faculty member at the same school as me in the School of Nursing at UC Davis. And so let's just go over the difference between cultural competence and cultural humility. So we first really started talking about cultural competence in the late 1980s and early 90s. And some of the thought leaders on the concept of cultural competence were really making some great points, which the primary thing was we should be able to care for each other across cultural and identity groups. And that remains true. I mean, the work that they were doing was really, really important. And I don't want to undermine that at all. But unfortunately, what happened over time when academics and healthcare providers got involved is that we wanted to reduce it to these things that we could quantify. And in trying to quantify things like cultural competence or cultural humility or the way that you interact with another human being takes some of the magic away and actually can like reproduce stereotypes to the point that like some of the questions that are asked around cultural competence is, you know, which of the following foods are part of African American cuisine? And as somebody who is mixed race, I find that very reductionist, you know, like from my white perspective and from my Black perspective, I eat a lot of different kinds of foods, right? So having somebody try to put me into a box like that doesn't really work. You end up stereotyping. And my question is, how are you going to take better care of somebody by reducing them to, you know, African American cuisine, right? You see what I'm saying? It's very, very reductionist. The genesis of the cultural humility framework actually came in the early 90s in the wake of the Rodney King riots. And I don't know if you remember that time, but in terms of technology, we had this great new technology where you could carry like a 10-pound camcorder and actually walk around and take videos of things. And so it was the first time that we saw a police beating on television. And, you know, we had heard stories, but we were actually able to see it televised. And we experienced this recently with the killing of Mr. George Floyd, that people were just appalled by what they saw. They were appalled by the beating of Rodney King. There were riots, there was unrest, people were upset. But one of the positive things that comes out of a movement like that is an inflection point. So there are also many people who had a desire to connect with communities that have been underserved, to connect with each other, to connect within the health profession to say, hey, how can we do better within the institution of healthcare? And one of the examples was the group that Dr. Turvalon and Marie Garcia were working with at Oakland Children's Hospital. And so they convened a group and created a curriculum. And I just want to point out some of the foci of that curriculum so that you'll get a sense of some of the key points of cultural humility. One is that we need to appreciate the great strengths of groups of people. Often in our reductionist approaches to people, we'll say, oh, those poor, you know, fill in the blank, those poor Hmong people or those poor Black people, and we really need to go in and save them. And that really is not a helpful framework. Every group of people has things that challenge them, but they also have wisdom and expertise. And we don't want to undermine that wisdom and expertise by thinking that we know better. So we need to, yes, learn about groups of people that are different from us and also understand their experience from a really a holistic view. We need, as healthcare providers, to engage in judgment-free history taking. And so this takes skill. How do you build a rapport, trust? How can you ask questions in a way that allows you to see the person for who they are rather than making judgments about them? For example, why don't you just diet and exercise, or you need to quit smoking or it's going to kill you, right? All of that is full of judgment. You should do this. There's some character flaw with you. Or for people that have substance use disorders, like we are so very judgmental about individuals that struggle with that. And that limits our ability to interact with them, to care for them, to prioritize them. And then the other thing is that they want to remind us that we can never become experts on groups of people other than our own. And so they use that as a point to say that you can never actually be competent, but you can engage in a process of continual learning. And that's where the framework of cultural humility becomes really important. Cultural humility provides a less restrictive approach that focuses on people's identities, and we will only know about their intersectional identities if we're in relationship with them and we're asking questions about them. Like if I were to ask you to describe yourself to me in just a few words, you get 3 words to describe yourself. What would you pick? You might pick you're a healthcare provider. Maybe you'll pick your gender. Maybe you'll say that you're a parent or a sister, or that you're a bowler. But do those 3 categories really give people a good appreciation for who you are as an overall person? And this is where that piece of intersectionality comes in. Like one aspect of your identity may be your race and ethnicity or your gender or something like that, but you've got so many other things that make you a unique person. Maybe it makes you somebody that represents a group of people, but perhaps you're an outlier within that group of people. You just don't know. And so the notion of, we use the word transformational pedagogy. This means that you appreciate that every human interaction that you have is an opportunity to learn about someone else. And I also want to add that the learning about other people and the connecting with other people is what brings the joy to what we do as healthcare providers. Like, again, if I was going to ask you, think about those moments when you've experienced joy in what you do. And for most people that answer that question, they talk about a time when they really connected with a patient or a family, or maybe it was a time when the team was working together in such a way that they were able to improve outcomes. And so it's that human connection that really keeps us going. Cultural humility describes a way of being. So it's not just what you do. What you do is a reflection of how you are in the world, but it's really about your beliefs and who you actually are. And that requires self-reflection, self-critique, understanding that none of us are perfect. We're going to fall down, and yet we'll keep getting back up and trying and doing better. And it's the active pursuit of lifelong learning, and we'll go into that a little bit more. So these are the 4 tenets of cultural humility. Like we said, lifelong learning, understanding, redressing, and trying to mitigate power imbalances, engaging in non-paternalistic community partnerships, and stewarding organizational level development and progress. So we'll get into those. Before we do, I want to share with you, this is another picture of Dr. Mara Garcia. She uses the analogy of scripts, that we need to understand that we have been taking in basically scripts about groups of people from the time that we were really, really little. And so she says that scripts reflect repeated, predictable thoughts and or actions that we learn in so many ways, whether it's our parents telling us to make eye contact or to say please and thank you, whether we're getting it from Sesame Street or from the evening news, we're taking in thoughts and notions all the time. Scripts reflect collective agreed upon thoughts, beliefs, and behaviors within a society that ensure consistent outcomes. And sometimes those scripts can be great, like the please and thank you, but some of those scripts can be negative too, and we are outgrouping people, criticizing people, stereotyping people, making assumptions about people. And the interesting thing is that we can soak in these social scripts in explicit ways because we're told, we saw it, but also in implicit ways. These can be learned through the things that go unsaid. Like if somebody makes a racist comment and nobody says anything about it, nobody steps in or confronts that, the script that we learned is it's okay to say those things, right? Scripts can also be the things that we tell ourselves over and over again, and those can be negative, like I'm not worthy, I'm not deserving, I'm a this kind of person, or I'm a that kind of person. Or it can be things that are self-serving in terms of I deserve this, I have a right to this, and those kinds of things. And oftentimes this ends up being a script that's in our head. I want to share some scripts in nursing specifically. This book here's a quote from this book. And it's talking about criteria that was used to select women to join the Army Nurse Corps in 1898. So first, recommendation letters from a physician and her head of nurses training that demonstrated a person's professional ability. And again, professional is a pretty squishy word. What do we mean by professional? Second, the committee sought to confirm the nurse's moral character and reputation. And if we go back into Victorian ages, we knew that what moral character and reputation was that women were expected to be virginal, not to be sexually active in any way. And so this was done through the form of a letter from a citizen of good standing in her community. And finally, a nurse had to prove her good health. So these were scripts of what nurses were supposed to do and look like and behave. I'm sharing this with you. A friend of mine who is a nurse shared this with me. Her mother was also a nurse, and this is her mother's report card. And if you see up there in the corner, it's from the date 1941. And so it's a written report card, and there are all these grades. So one of the areas I have circled is the category of deportment and personality. So you're actually graded on your personality. And so you got a grade on sense of humor, sincerity. I don't know what self-control means. Does this mean that you limit the amount of donuts that you have, that you're not throwing yourself at your patients? I don't know, but it seems like there's a script there of what folks are supposed to do. And it wasn't in our too distant past. And sometimes people try to enforce this now, that you get a grade on your dress and your shoes and the arrangement of your hair. Again, there's a script of what it looks like to be a nurse. And of course, probably different standards for women and for men. All interesting stuff that we've taken in over time. Here's another one, script of professionalism in nursing. This is from a 1967 article called The Doctor-Nurse Game. And what he observed in 1967 is this script: the nurse is to be bold, have initiative, and be responsible for making significant recommendations, while at the same time, she must appear to be passive. This must be done in such a manner so as to make her recommendations appear to be initiated by the physician. Rules of the game, the cardinal rule of the game is that open disagreement between the players must be avoided at all costs. Thus, the nurse must communicate her recommendations without appearing to be making recommendations. The physician, in requesting a recommendation from a nurse, must do so without appearing to ask for it. So I don't know how that's hitting you. I can't see any of you at the moment, but I know that when I read that just a few years ago, I was like, that is still a script that exists today within the interactions between nurses and physicians, right? It may be not as overt as it was in 1967, but you can still feel that. I know that when I graduated in the 90s, our nursing instructors were saying, you know, it's really important for you to know that nurses are no longer giving up their seats to physicians, which was kind of like, whoa, that's a crazy script that nurses would give up their seats to someone else as if they're more important somehow. Another way to think about scripts was something that was written about and talked about by somebody named Beverly Daniel Tatum. She's got a book out there, which you can see on the screen. And this is a quotation from her from an interview. She says, books, computer games, the web, television, there's so many places that we can be exposed to stereotypes, that we can be exposed to distorted information. And there's a whole universe of information that we're not getting. Think about these stereotypes, these omissions, these distortions as a kind of environment that surrounds us, like the smog in the air. We don't breathe it because we like it. We don't breathe it because we think it's good for us. We breathe it because it's the only air that's available. And so when you hear people, and hopefully you're not saying this, and if you are, I want you to rethink it. If you say, there's not a racist bone in my body, there's just no way that I could be racist in any way, shape, or form, I want you to compare that to someone saying, well, I'm an environmentalist, very committed to the environment. And because of that, I've decided that I'm not going to breathe in smog. Smog is not good for me. I don't believe in it, right? Like that's somewhat ridiculous. And so it's the same with racism, that you may have values that are very much against that. But the notion that you have grown up in a society with media, with other people, with human interaction, and you've never taken in a script about that is like a racially based script is kind of ridiculous. Like we have all taken that stuff in. And so if those things are lurking around in your brain and they're probably not in alignment with your values, but they're there. So are you just going to ignore them and pretend they're not there? Or are you going to take that time to engage in lifelong learning, to undo some of those scripts, to take care of some of that smog that you've breathed in so that you can take better care of the patients that you work with? So I want to share some examples of scripts and sort of institutional inequities. One of the things is the notion of the Scholastic Aptitude Test, the SAT. A lot of us had to take that to get into higher education. And the SATs are really the first standardized exam that was created. It's the father of all standardized exams. But do you know where it came from? It was developed by somebody named Carl Brigham, who was an ardent eugenicist and was part of like the National Eugenics Society, proud member of the National Eugenics Society in the 1920s. In 1923, he published a book. It's here on the slide. It was called A Study of American Intelligence. And basically what he was trying to do was to prove that white people are smarter than Black people, Italians, Jews, all these different groups. And he stated, our results showed the marked intellectual inferiority of the Negro are corroborated by practically all the investigators who have used psychological tests on white and Negro groups. So it has the veneer of science, but it really isn't science. It is people trying to prove an opinion that held up one group over another. So he published that in 1923. Interestingly, in 1926, he put out psychological tests onto the market that are called the Scholastic Aptitude Test. It's a multi-billion-dollar industry that is still in practice today that, guess what, shows consistent outcomes, that white men perform better on these exams than do women or people of color. And for a long time, if people of color and women started doing better on the exam, they would change the questions, figuring there's something wrong test. And so it makes you wonder about the validity. What is it that was actually being measured? Was it intelligence, or was it access to the secret sauce? You know, people pay tons of money to go in and take SAT prep courses. So we know that people who have access to those resources and learn how to take these kinds of exams do better on them. And it may not have any bearing on who is actually more capable in school. And we certainly know that, you know, the nursing boards are not predictive of who's going to be a good nurse and who's going to be a bad nurse. We have people that do really well on the boards and they're terrible nurses, and people that really struggle and they're fabulous nurses. So that is one of the scripts that we have taken in over time in our society, that Black people are not as smart as white people, or people of color are not as smart as white people. So what does this mean in healthcare? The print on this is small, but you'll see that this is a newspaper article from October 21st, 2021. So that is our very near history. And basically, the NFL agreed to end race-based brain testing in a $1 billion settlement. And so it says the league had agreed in June amid an uproar to halt the use of race norming, which assumes Black players start with lower cognitive function, and it makes it harder to show that they suffer from mental deficit linked to their playing days. So basically, you know, football players get hit on the head a bunch, and they can qualify for disability insurance and payment because of the damage that they sustain. But because they had a different test for Black people than white people, they basically said to Black people, there's no indication that there was a change for you because you started so low and Black people are so low anyway. And so they weren't qualifying. That's actually a medical problem. And we see these medical problems happening when we do like race-based testing for glomerular filtration rate. There has been an adjustment for that based on race and ethnicity, which is like super weird. The assumption is Black people have more muscle mass than white people. Like, that's ridiculous. If you take, you know, 110-pound Black woman and compare her to like who, like Arnold Schwarzenegger, you're going to say she's got more of a muscle mass than he does? That doesn't make any sense. And then somebody who's mixed race like I am, can you look at me and estimate how Black I am? And how are you going to determine then what is the right normed GFR for me as a mixed race person? Like, you can see that it's fairly ridiculous. Some of the other scripts that have been out there, this is an image from the very first Hollywood blockbuster film in the US. It was put out in 1915. And this picture here, you'll see this guy who's in blackface. This is a white man dressed up as a Black man. This is why people are so sensitive about the use of blackface, because this person dressed up as a Black person and played like the worst stereotype tropes of Black men as being violent, as being stupid, as being aggressive and dangerous. And, you know, that is a script that has continued in Hollywood over time. We do see some progress with it, but in my growing up, you know, whenever we as a Black family would look at movies, it wasn't if the Black person was going to get killed, but when. And you would see a theme throughout movies that Black people were rarely the heroes or the stars. They were usually a supporting role, right? And so, you know, it's almost like that's the omission. Like, if you don't see yourself as the Supermans or the Batmans or the Ironmans, there's an implicit message that's being portrayed across our society. So it's basically what is said and what is not said. So Black men portrayed as violent, scary, monstrous. And in this book by Robin DiAngelo, she talks about things like Lord of the Rings. And I just, don't get me wrong, I have been a Tolkien fan since I was little. I had a room where the door to my room was like a hobbit hole. Like, my family is definitely into Tolkien, seen the movies a bajillion times, read all the books. Tolkien never specified the skin color of the characters. But when you look at Peter Jackson's version of it, you see all of our heroes are white. And then the bad guys, the orcs and the Uruk-hai, are all people of color. And so, yeah, maybe if that was a one-off, but as you start looking at themes, you'll see that's not an uncommon theme, that white is associated with good and Black is associated with bad. And again, we're taking in those scripts. Let me just go over a couple of these bullet points about incarceration. So a Black person is 5 times more likely to be stopped without just cause than a white person, and 1 out of every 3 Black male youths born today can expect to be sentenced to prison. Not only are Black men locked up at higher rates, but their experience of incarceration is usually harsh and solitary confinement is common. And then when they were talking about the Michael Brown case in Ferguson, Missouri, they said that they concluded that the harms of Ferguson's police and court practices are borne disproportionately by African Americans, and there's evidence that this is due in part to intentional discrimination on the basis of race. And this is important because the police officer who shot Michael Brown said he looked like a monster, like a demon, and like he had superpowers. And you know what? Because I think his name was Derek Chauvin, had probably seen this trope over and over and over in the media. That's probably where his brain went to. That's like that unconscious bias, that script that he has taken in that led to this particular outcome. This happens in healthcare as well, that we make clinical decisions based on the scripts that we've taken in, whether we're connected with those scripts or not. Excuse me. So think about the story of Serena Williams. She, in the HBO series called Being Serena, she describes her experience going in to have a baby. And while she was there, she, after the birth of her baby, she had chest pain, and it was actually a familiar chest pain for her. And she was saying, I'm having a hard time breathing and my chest hurts. And they were dismissing her. She talks about this. The father of her baby was witnessing this too, that she's like, no, really, I'm having a hard, oh no, you're just a first-time mom. First-time moms are always worried about stuff. Don't worry about it, you're fine. And she talks about how hard she had to work to advocate for herself. And finally, they indulged her and did the test. And lo and behold, she had a pulmonary embolism, which people die from. And they caught it, they treated it. We know that she's okay. But there are so many cases when the Black woman is not listened to. And I can't help but wonder if in Serena's case, her celebrity didn't help her. Like, who wants to be the nurse or the doctor when, you know, you've missed a scan and resulted in the death of a celebrity? But there are folks where the outcomes were much different. And I want to bring your attention to something that's on YouTube. I highly recommend that you Google this video. It's called the Kira Johnson story. And here's the link for it below. Similar situation where she went in to have her baby, and after she had the baby, she had bleeding in her catheter, and they ordered a stat CT scan, but the hours just ticked by and they didn't do that CT scan. And her husband, they were like, where's the CT scan? And they said, we're sorry, she's just not a priority right now. And so 7 hours after that CT scan was ordered, it was finally done. And they're like, oh my gosh, she's bleeding. Let's take her back to surgery. You know, she'll be back in 15 minutes. We'll take care of it. Well, when they opened her up, she bled out and she died on the table. And, you know, this was a conglomeration of clinical decisions that were made along the way. She was deprioritized. I mean, one of the main things that we do as nurses and in healthcare is we prioritize patient needs. Well, why is it that Black women are so often deprioritized to the point that we see quantitative data that just shows significant disparities in maternal outcomes for Black women in the United States. And we see the qualitative stories like these ones that indicate that this is true. So it's not just happening randomly. And humans have a part in that. And what I'm suggesting to you is that in those moments where we're making critical decisions, whether we like it or not, we access some of those scripts that we've learned over time, and they inform the decisions that we're making. And those decisions result in poor outcomes for certain groups of people. There are scripts that are very old. The script about pain we saw in a book written in 1787 where Benjamin Moseley was trying to make a case that Black people did not feel pain like white people did. And he made ridiculous statements like he had amputated the legs of many Negroes who then held the upper part of their limbs themselves. Like, are you kidding me here? Like, that is just ridiculous. The script is old and it's dehumanizing. We have also seen this with somebody that was lauded as the father of gynecology and up until 2017 had a memorial in front of the American Medical Association. He was someone who experimented on enslaved women without their consent and without anesthesia, saying that it's not painful enough to give them anesthesia when he was basically doing surgical repairs on the area on a woman between her vagina and her rectum. It's called the vesicovaginal fistula repair. So he was doing that without anesthesia, without consent, and the idea was that Black people don't feel pain like white people do. So we say, yeah, that's way back in the past. Well, not too long ago, there was a study that was done on medical students and medical residents where they asked them questions about, whether Black nerve endings are less sensitive than white nerve endings. And so here are the results. I'm going to start with first year. So there's a sample size of 63 students. And of that 63, 8 of them, that's a significant number, believed that that was true. Second year medical students, there was a sample size of 72. Of that 72, 14 of them thought that was true. Yay, third years, 59, and 0 of them thought that that was true. You go. And then with medical residents, 28 were in the poll and 4 of them thought that that was true. So these are basically people. Think about where these folks are today. This was done in 2016. So all of these folks are probably practicing physicians at the moment who believe that Blacks do not feel pain like white people do. And they're out there right now making decisions about who gets pain medication and how much they get. That's disturbing. We know from the literature that this is a big problem. Here's a meta-analysis that was conducted in 2012, where they said our study quantifies the magnitude of analgesic treatment disparities in subgroups of minorities. The size and difference was significantly large enough to raise not only normative, but quality and safety concerns. The treatment gap does not appear to be closing with time or existing policy initiatives. A concerted strategy is needed to reduce pain care disparities within the larger quality care initiatives. Unfortunately, this is not only true for Black adults, but Black children. I have highlighted, these are colleagues that I work with at UC Davis that did research on children that came into the ED with appendicitis and abdominal pain and found that these disparities in analgesia existed for Black children as well. White children coming in with the same exact clinical presentation were more likely to get pain medication than were Black children. In nursing, we're not exempt from this. It's hard to see. I wish I could give you a better image, but this is what I have. It's from a nursing textbook. And at the end of the textbook, like at the end of each of the chapters within the textbook, they would have a focus on diversity and culture. And so it was like they were talking about the same things that they always did. And they said, okay, at the end, we'll talk about differences in groups of people. So this is what they had for the pain chapter. They talked a whole chapter on pain. And then they said, here are cultural differences in responses to pain. And here are some of the stereotypes that they've made. So here's just a couple. For Asians, they said, Indians who follow Hindu practices believe that pain must be endured in preparation for a better life in the next cycle. What does that teach nursing students? That teaches nursing students that they're doing people who practice Hinduism a favor by not giving them pain medication. For Black people, they said, Blacks often report higher pain intensity than other cultures. So let's just rephrase that. They're saying that Black people exaggerate their pain. And when you combine that with a belief that many people have that Black people don't feel pain to the same extent, you have some reasons why there would be such normative and quality differences in the pain treatment for people of color. If you're Jewish and you're feeling left out, don't worry, there's stuff here for you too. It says Jews may be vocal and demanding of assistance. So one thing I want to draw your attention to, I want to learn more about white people. Where's the category for how white people respond to pain? They're not there. That's the omission part, right? And what we take in from that omission part is that the way that white people, an overly broad category by far, but that white people's pain is the normal response to pain, right? So some nursing students pushed back at the publishing company, and the publishing company actually issued a public apology and removed this textbook from the market. I believe this was the 2015 edition, and I can't help but think how many generations of us were learning these stereotypes when we were coming up in nursing school, right? So the damage is there, the damage is happening, and we see that in our statistics. So just to bring it all home is that race does not have biological meaning. It is a social construct that has historically been used as a mechanism of oppression. Racism is something that we do to each other. So one of the reasons that we see differences in health outcomes based on race is not because we're biologically different. It's because we are experiencing a higher level of stress, which relates to allostatic load. Allostatic load is the wear and tear, weathering of the body over time in response to stress. The biomarkers for that are the presence of stress hormones and hypertension. And if you think about what happens under the stress response, you realize that constantly being in the stress response leads to things like cardiovascular disease, hypertension, biomarker, diabetes, suppressed immune systems, obesity, all of these things. And so racism then has very real outcomes for individuals. So what Dr. Murray Garcia and Turvalon say about scripts and why we need to understand it is the skill we must learn then is to identify these personal, institutional, and historical scripts of inequality so we can interrupt them before we initiate or are pulled into the performances that can result in cultural disrespect or lower quality of care, oppression, or the perpetuation of structural inequity. And how do we do that? It is through lifelong learning is one of the ways that we can do that. And so one of the ways that you can think about this, just a reflection question, are what are assumptions that are made about patients? And you can think about all kinds of patients. It doesn't just have to be race and ethnicity. What assumptions are made about patients that come in and use foul language, that smell a particular way, that look a particular way? What assumptions do we make about people who come in and say that they have back pain and may I please have some pain medication for that? What assumptions do we make about people that are living with obesity, that speak a second language that may look different from us based on race, ethnicity, or have cultural differences? And so then the next thing to reflect on are what assumptions have you made? And how have those assumptions impacted your care? And honestly, this is what keeps me awake at night. How do my biases impact the way that I function as a nurse, and a faculty member, right? We need to unpack that because we know the stuff is there, but what is the effort that we're putting into unpacking and rewiring that? Just talking about the notion of the humility part of cultural humility. So the Cambridge Dictionary defines humility as the feeling or attitude that you have no special importance that makes you better than others, like a lack of pride. Another definition is humility is the disposition to view oneself as basically equal with any other human being, even if there are objective differences in physical beauty, wealth, social skills, intelligence, or other resources. And humility is the key to wonder. As humility grows, wonder deepens, and oftentimes it's through wonder that we experience joy. So it's this middle one that I really want people to think about in terms of healthcare providers as we start to tee up for the next one, which is power imbalances, is how do we sometimes leverage what we think we know and what we are going to tell patients they need to do for their health, thinking that we know better than they do. I'm going to skip that one. So redressing power imbalances. So this is really understanding your position and right-sizing that to the individual situation, group, or whatever you're in, and also understanding your positionality within a myriad of hierarchies. This can be within nursing. You know, how are you treating the people that you work with? Recognizing that as a nurse, you can sometimes walk into a situation and have power, and walk out of a situation into one where you don't have power. And it also means looking at the societal position that you hold. Sometimes there are groups of people that have power because they're white or they're upper middle class, they dress a particular way, all of these things. So you may be walking in and out of power, and it's easy for us to think about those moments when we don't have power. But what about those moments when we do have social or actual power? And are we making attempts to right size that so that we're not abusing our power or misusing our power? So just think for a moment, what are some of the ways that healthcare providers, nurses specifically, can and do leverage their power in clinical environments? I mean, we're the ones that are gonna either help or not help, right? We can leverage our power in the way that we reinterpret what a patient says in the way that we give report to other care providers, if we're gonna give them pain medication or not, the way that we stand in the room, the way that we will sometimes lecture people without even getting a sense of, do they already know the information that we're given, right? So just some different things to think about in terms of right sizing some of those power imbalances. The other thing then is engaging in non-paternalistic community partnerships. So this, again, we talked about this earlier, means that we honor the expertise that exists in the community. The one-way flow of expertise from like a medical center or from a healthcare provider to the community or to patients, we see ourselves as the ones with the expertise and the answer. And a lot of times we're actually not the ones with the answer. We need to be listening to folks that live in the communities. They often know what's best for them. Patients often know what's best for them, but tend to get dismissed a lot. I remember once having a care provider say, yeah, it sounds like you think you know your body. And I was just like, I don't think I know my body. I am in my body. I know my body more than anyone who spends 5 minutes assessing my body could possibly know it, right? I know when I feel pain in a different way than I did before, when I feel differently than I did before. And we need to listen to that. Another thing that drives me crazy is when I'm a really hard IV stick, and I have this place on my hand that I don't know why providers try to start an IV here. It's a really painful spot. I tell them that's not a good spot. Let me tell you, as a former ER and ICU nurse, that is not a good vein. And yet they'll go there. Nobody has ever gotten it there. And every time somebody has poked me there, I've gotten a big old bruise as they blew the vein. And it's like, why won't they listen to me as somebody who knows my body, who has had IVs attempted there so many times, and yet this just happened to me a year ago when I went in for my colonoscopy. I was like, oh, you're killing me with this, right? So we need to listen to our patients, we need to listen to our communities and stop being so paternalistic. And the other thing is not going in with a savior mentality. We are not the saviors of other people. We can be there to support, we can lend the knowledge that we have, we can help people with resources, but we need to work in partnerships with where there's a back and forth relationship, a sharing of information happening. Okay, we said that already. So then the reflection question for you is, in what ways does paternalism manifest in the clinical or the care setting? Are you being mindful of that? And in what ways can we as healthcare professionals, and in what ways can we as individuals begin to stop doing that and really honoring our patients and communities? Okay, and then the last one is really about stewarding organization level development and progress. And this really parallels the first three tenets, but recognizes that we need to do this at the organizational level as well. And this brings me to some poll questions. Celeste, if you are there, I would love for you to launch the poll question, although I think I did this backwards. Hang on a sec, don't answer the poll yet. I put the poll before I did the slide that explains the poll. So the poll's up, hang on, let me explain the poll to you. So I want you to look at this continuum on becoming an anti-racist multicultural institution. So you'll see at the top of this that there are different sort of categories for an institution and where they are in their process. So an exclusionary or exclusive institution is an institution that is intentionally and publicly excluding groups of people like African American, Native American, Latinos, and they're known for that. A passive or club institution is a group that they'll let people in, but only a small number of token people of color. And they might in some ways, whether overtly or covertly, try to limit the progression of people in the organization, or make sure they don't have too much voting power or too much power in the organization. So that would be a passive organization. A symbolic change organization, they're the ones that are only motivated when an accrediting body comes in and says, you need to be doing stuff. Otherwise, they're not going to do it. And that's called a compliance organization. So an identity change organization or an affirming organization is an organization that has growing understanding of racism as a barrier to health equity, and is starting to develop processes where they evaluate this and they're trying to do better. Structural change or a transforming institution, it's committed to, and it is actually implementing processes that decrease the amount of disparities that are the output of that. So you would see that there are fewer healthcare disparities within this organization, or if it's like a school of nursing, that there are fewer educational disparities that are happening. And then the last one is a fully inclusive, anti-racist, multicultural organization in a transformed society. So basically, you're the model, and other institutions should be modeling. And a lot of them already are modeling what you're doing at your institution. So the poll question then is for you to think about the organization that you work in. Where does it fall? Where do you think it falls right now in this moment in time? So now we'll go ahead and start that poll. Let me know where you think your institution is on that continuum. So Celeste, I'm going to let you kind of get a sense of how many people have voted and when it's time for us to see that. Oh, great. All right, this, I'm hoping that you can see what this says. So basically, nobody said that their organization was exclusive or passive. So that's a good sign. An exclusionary institution is really an outlier. And I would say a fully inclusive, anti-racist, multicultural organization, that's also an outlier. So you guys, nobody voted for 1 and 2. There is a normal distribution. If I look sideways, 14% said a compliance institution. 32% said an affirming institution. You got folks that are really working on this and find it important. There are a lot of you that think that you're a transforming institution, which I find fascinating. I don't think that there are a ton of transforming institutions, but there are more and more. And I'm going to say that, again, an organization in a transformed society, that's also an outlier. I don't know that there are very many, if any, because what it suggests is that your organization doesn't have any disparities, that you're a perfect organization working within a system that is also doing really well. And there could be some groups that you're doing well with, like maybe you really have addressed the homeless population, but you might have people that are still struggling with diverse ability. All right, so I want to see could we launch the next poll question, which is a little bit different. So that one asked where your institution is. I want to know where you would like to see your institution go. So go ahead and take a moment to click on that and let me know where you would like your institution to go. All right, Celeste, show us the results when you think the time is right. All right, lovely. So the results of this one are quite different than where we are to where we want to be. So in this one, nobody voted for the first 1, 2, 3, 4. And everybody voted that they either wanted to have a transforming institution or an organization in a transformed society. So the reason that I show these together and do these together is to demonstrate that we're not where we need to be. We have some work to do if we're going to move from where we are to where we want to be. And how we get there is really, I'm going to go ahead and we can go ahead and close that. And I'm going to move to the next slide. This is where the action piece comes in. And of course, I can't tell you what AA or AAACN should be doing. I can't tell you what you should be doing within your respective clinics, because you all have different needs and different populations. But what I can say is that you need to have a strategic plan that is specific to reducing health disparities and health equity. So what is it that you're going to do? You're never going to be able to do something if you don't even know what it is that you're seeking to do. So you say the what, and then from there, you need to have an action plan. So if we've said this is what we're going to do, we need to march out what is it going to take for us to get there. And as you're talking about your strategic plan and your action plan, you need a lot of diversity at the table. You need an interdisciplinary team. You need a team that reflects the many different demographics of the communities that you serve, agreeing on, from a cultural humility standpoint, that are agreeing upon what the goals are, and then what is the best way to get there. And that process is a hard process to do, but I can promise you that if it is people behind closed doors with just a small group of people representing a small group, you will never find that action plan that is going to get you from point A to point B. All right, so what I want to do now, in case any of those citations or references were really resonating with you, here they are again. But I do want to spend some time now checking to see were there questions or comments or reactions to what we've talked about today. So I'm actually going to stop sharing. If you have a question or a comment, this is the time to put it in. So I'm looking at the question and answer. Let me know, Deborah, if there's anything in the chat.
Don't see anything yet.
I never know, is lack of comments because everybody's like, yay, we totally agree and we got this, or is it that people were so confused they don't even know where to begin? Not sure.
They may be just typing.
They're just typing. I should have invited people to ask questions a little bit earlier. Deborah, did you have any questions or comments?
I did.
Yeah.
I was wondering if you could elaborate a little bit more on the savior, the savior piece, because sometimes as nurses, we want to fix things, right? We want to jump in and fix things. So can you elaborate a little bit more on like examples of what would be a good way to do that?
Yes, I am happy to. And you know, one of the things is that the reason that we came into healthcare, like when I ask groups of people, why did you choose healthcare? Of all the things that you could have chosen, why did you pick healthcare? And usually it's our desire to want to help and do good. And that's well and fine. But sometimes what we like to do is we like to come in and feel like we are the person that is making the change, that we're the ones that are responsible for the change. And therefore, we know what other people need, and we are going to be the ones that save them. And really, it's coming from a place of egoism, that it makes you feel good that you have done this thing to another person, right? Versus the idea that what you're committed to is the outcome, which is great patient care. If you are interested in great patient care, it's going to be a collaborative, and you will, instead of like giving yourself credit for it in your head, you'll be like, you know, I am so happy that I got the opportunity to work with you as a family, as a community in this process to wellness, right? Like there's a small shift in there, but it's a really important shift. One of the ways that I see this in my faculty position is that a lot of nursing faculty want to be the ones that students come to, that they confide in, and that they're the trusted one that always helps students, right? And that is a self-facing value system. If you truly care about your students and you truly care about your patients, you'll make sure that they have a large network of people that are there to support them and give them the resources, that it's not really about you. Okay, so I'm seeing some stuff.
Yes.
Okay, yeah, that thing about standardized testing, indeed, that blew my mind. And I think it's important for us to understand this, and that this can be an example of what else do we not know about the policies and procedures that are out there. I mean, a lot of times people say, well, why are we talking about our past and our history? What does that have to do with now? Well, our past and our history has everything to do with now. Okay, let's see, I'm going back up. Do you recommend specific toolkits for organizations who are on this journey? There is a website called raceforward.org that has, it has like a self-assessment tool that you can kind of get a sense of where you are as an institution. There is also a link. If you go on to the American Nurses Association California chapter, I have been working with a group of people that created a racial assessment where I think it's a little more geared for hospitals, but I'm pretty sure it would work for clinics too, where you basically do a self-assessment of like, are you doing DEI classes, and how much are your leaders supporting DEI efforts? So it gives you sort of a snapshot and some reflection points about where you are. So those are the ones that are coming to the top of my mind. Do I have ideas for what AACN could do for its strategic plan? This is going to be very personal for the group, but I suspect that you probably have a mission statement. And I apologize, I have not looked at your mission statement. If it does have something about health equity, yay, then the next step is, okay, this is part of our mission. What pieces of health equity do we want to get to, or what pieces of health disparities do we want to address? What do we need to do as an organization based upon our mission? And then you want to make clear, measurable goals, like be clear on the definitions and be clear on how would you know if you met those goals. And then of course, the next thing would be to create the action plan for getting there. And I think it's really important to make sure that you have buy-in from the entire Academy of Ambulatory Care Nurses so that it's representative of, and that people within the Academy see themselves and their populations that they work with and that they may be with reflected in that strategic plan. You want everybody to look at it and say, yay, this means something to me and the groups that I work with. Let's see.
We do have some other questions in the Q&A. Did you want me to read them to you?
Absolutely. And I'll click over there as well.
Okay.
Ooh, okay, Jessica, you're just going to throw down with some hard questions. What's the difference between cultural humility and cultural intelligence? So I, again, do not feel like concepts need to be in competition with each other, but rather that they're talking about different things. So cultural humility is really a way of being in the world. It's kind of like, what is your goal and your ambition? How are you connecting with and appreciating other groups of people? I would say that intelligence, cultural intelligence, has more to do with knowledge and skills, and maybe your ability to assess what groups of people are different from you and how, and that those things are really important in your practice. Like that's part of the lifelong learning. One of the critiques that you would see about a term like intelligence is, a lot of times we have a fixed mindset about intelligence, like you either have it or you don't. And when we talk about intelligence, we want to make sure that we're on a growth mindset, knowing that we can expand our intelligence through the process of lifelong learning. Just a comment, I've never heard of the NFL testing prior to tonight. Thank God it was discarded. I have to say that when I read that in the paper, I snatched it because it was really indicative in many ways of, what we thought was a past practice is still in practice today. And we want to make sure that we're shining a light in the corners and recognizing some of those things that seem normal to us, but are continuing to be in practice. So yes, that I hadn't heard of it before I read that article, and I was dumbfounded as well. Oh, have you noticed any differences between religious healthcare organizations and non-religious organizations as it relates to DEI? I think that, I don't want to get into a comparison. I don't know that anything good will come out of that, but I think that one of the things that we can do is always bring it back to the mission of the organization. So I actually am getting a recognition from a Catholic school of nursing. I'm not Catholic, but one of the things that I do is I look to say, what are the things that they are doing as an organization that are based on their religious practices that resonate with my practices? And, you know, always within the Catholic institutions have been, we are supposed to be in service to other people, right? That we're supposed to be making sure that people that don't have their needs met have their needs met. And so it's really about envisioning what's the commonality, what's the goal, why did we all come into healthcare? What is it that we have said as a nursing profession that we want to do? And that's to be in service of and to make sure that different groups of people are getting the care that they need to. So honestly, I have seen varying degrees of an engagement with DEI, but I don't know that I could correlate it to them being religious or non-religious. Sometimes it has to do with geographic location. It has to do with profit, nonprofit, different things like that. All right, I'm looking at some of the, thank you so much for all of these great things. I was a volunteer in the 70s, became a nurse in the 80s. I remember standing up when the doctor walked in and having to carefully couch questions. Yes, yes, to make sure that that they can hear it and still feel like it was their idea. Yep, I can relate too. I feel like I've experienced that in the 90s and in the 2000s. A comment about having seen so much bias and misinformation about pain tolerance and cultural differences, especially lumping similar cultures, right? Thank you for sharing those resources. Absolutely. I'm really happy to know that that is helpful for you. Some of the other areas that I've been delving into, you saw me go into maternal health outcomes. Another area where there's a lot of disparities is around mental health, that we have historically seen diagnoses like drapetomania, which was a diagnosis given to enslaved people who didn't want to be enslaved. Like that, basically the idea is that you were crazy if you didn't want to be enslaved and taken care of by your white masters, right? So there are several things like that that have existed historically. People that would protest in the 60s and 70s around civil rights were said to have protest psychosis. So yeah, many areas. Absolutely, talking about maternal health, there's so much there that we need to unpack and make better. I think I answered the organizations one. Oh, what is the difference between a script and implicit bias? I would say that there's really not a big difference between those notions, but the script analogy helps us think about it in a different sort of way. I think that sometimes people sort of, you know, phase out when they hear implicit bias, like it's become a buzzword, and what does that mean? And scripts help us understand how we got to a place of having implicit bias. Like it's not like we made a choice to do that, it's that we're all taking this thing in. So it's just another way to think about a similar sort of a topic. Let's see, did I miss any here? We talked about the strategic plan. I'm feeling like it would be a whole other session where we would need to talk about the strategic plan. And I'm happy to come back and talk with you guys at some point if you do get to the place where you want to sit down and say, okay, we're working on a strategic plan. But what I would recommend is first steps along that is to convene a group of people to just start brainstorming. What does it mean for us? How can we make this happen? Awesome. Wonderful. Well, we are at the hour. Deborah, I want to hand it back to you. Thank you so much for your lovely questions. Thank you for spending this time and listening to this topic. I really appreciate that.
Thank you, everybody, so much for joining. We really appreciate your time and attention. And we want to thank our speaker so much for spending her time and her knowledge with us. It was very, very interesting and so helpful, especially as we're all on this journey to make the world a better place. Thank you so much, everybody. Have a good night. Bye. Thank you, Dr. Ackerman-Barger.